Okay. What sterile gel have you used? Because yesterday we were talking about this, and somebody asked this
It
question.
comes, the sterile gel comes within the, it is an ultrasonic, um, it comes within the transducer pack,
Okay.
the transducer sleeve that we use.
Okay. So this comes with the sleeve. It's a complete
Yes,
pack.
it's a complete pack.
How much does it cost for single use?
I think it costs about $5 where we are, so,
Okay.
and so we came with a standard kit, and the kit has everything that we need for,
Can you focus on the kit little? Yeah. Okay.
it has, all the preparation. We have chlorhexidine preparation, we have the drapes, we have two vials of local anesthetic solution, we have the gel, we have the probe cover, and for dressing we have Steri-Strips, Tegaderm, and tincture benzoin.
What is the local anesthetic you are holding here?
That is 1% xylocaine or lidocaine, just used
Okay.
for the skin infiltration.
Okay.
And we have the needles and everything. So it's a complete pack. You really don't need anything else. This pack will be able you'll be able to put in a stimulating catheter in any location of the body.
The needle is also part of the pack?
Yes, everything is part of the pack.
Okay.
And we've already sort of included the TUI needle, which is a 17 gauge TUI needle, insulated. And we also have the stimulating catheter. And we wanted to show the drape. This is a clear drape, so you can see all parts of the body with the eye with an opening where you're actually doing the procedure.
Yes, we can appreciate that. Yeah.
Okay, so we'll start, and so I'm going to see the femoral nerve, which is right next to the femoral artery, just lateral to the femoral artery. So, sui, chota sa sui लगेगा, okay?
Your orientation marker, I suppose, is on lateral side, is it?
Yes. So
the picture on sonography screen is the right side is the lateral side.
So that side is medial, and now where the arrow is, that is the lateral side.
Yeah, correct.
Okay, so you're going to start skin infiltration. We're going to put the lateral edge of the femoral nerve in the center of the screen, and I'm going to go infiltrate slightly off center on my screen. So I create a good skin wheel. And it's a 17 gauge TUI needle that's going to be going in, so we infiltrate fairly deeply.
Yeah.
And you can see some of the layers.
Yeah, layers getting separated.
Yeah, layers getting separated.
Nicely.
And so we create a good sort of local infiltration along the path of the TUI needle. So we'll start if you can turn the stimulator on at 1.0. Oh, here's the needle. This is the TUI needle. It's an insulated TUI needle.
Yes, it seems to be a pretty long needle.
Yes, it's a 10 centimeter gauge needle. Right.
Okay.
They're just going to change the location of the camera, so we'll just wait to insert the needle.
As we can see, the depth kept is something.
The
like
depth is about 1.5
centimeter.
centimeter. That's right. The depth is about 1.5 centimeter.
Yeah, depth on the screen is 4 centimeter total depth.
Oh, okay.
Meanwhile, can I request auditorium managers to increase the AC, please? Please increase the AC of the auditorium.
There's battery. Turn it on. 1.0. That's it. So we have the needle hooked up to a stimulator, which is set at 1 milliamp. I'm going to insert, and I'm going to bring my needle right next to the lateral edge of the nerve. As you can see, this is an out-of-plane technique. I'm right over the fascia. As soon as I cross that fascia, I should start seeing stimulation of the quadriceps muscles.
Okay.
And there, I've just gone through, and you can actually start seeing the...
Yeah, we can see the twitching as well as your needle reaching the lateral edge of the nerve.
So can you change the frequency of that to... it is at 1 hertz. Can you change it to 2 hertz? Do you know how to change that? Okay, just leave it at 1 hertz. That's fine. So, so my needle is right at that lateral edge.
Yes.
And
what is your target? Would you
The
like
target
to go
is that
behind
lateral.
the nerve or anterior to the nerve or
No,
lateral to the nerve?
it is just lateral and maybe a slightly inferior to the nerve.
Okay.
As you can see, is it working? Okay.
What is the stimulator setting at the moment?
It's at 1 centimeter, so I've gone too deep.
No, this current on the
It's 1 milliamp.
1 milliamp. And what are you planning to do now? You reach the lateral edge of the nerve.
Right, and I should be seeing stimulation, which is everything hooked up? Yeah. So go to 1.5.
Is the connection proper? Because
Yeah, so I'm just going to withdraw my needle and go again one more time.
even there you should see some stimulus reaching the
There.
nerve.
Yeah, yeah. So now if you can see the contraction of the quadriceps
Yes,
muscles.
you can see that, yeah.
I'm going to take my stylet out, and we're going to hook it up to the stimulator, change the stimulator. Just disconnect from there. And now the needle is hooked up to the stimulator, and we're going to start inserting. As soon as we insert, you start seeing the contractions. And as we advance the catheter, you can see how I'm advancing the catheter, and I'm still able to maintain the contractions.
Okay.
So the catheter has been inserted about 4 or 5 centimeters right now, and you have good contraction of your quadriceps muscles.
Oh, the nerve stimulator is still attached to the needle itself.
No,
and not
the stimulator is attached. The catheter is attached to the nerve stimulator, not the needle. It is the catheter that is attached to the needle.
Initially, it was attached to the needle, is it?
Initially, it was attached to the needle, and then when we started
Okay,
to
you
thread
changed it to, huh.
the catheter, then it was attached to the catheter.
What is the solution conducting the current?
No, there is no solution. We haven't injected anything.
How does the current reach this?
It is attached. So here's the catheter. This is the end of the catheter. There's the catheter, and it is attached to the nerve stimulator box. So you're stimulating through the needle, through the catheter. Sorry, you're stimulating through the catheter. The needle is no longer attached to the nerve stimulator. Here's the.
Okay, that is to confirm that the catheter is lying perfectly inside the sheath and touching the nerve.
That's
is
correct.
it?
That's perfect. So now we're going to take the Twin needle out and leave the catheter in place.
Still the current is same, or
Still
have
the
you
current is
reduced
same. The current is we leave it at 1, and that's how we do it. So
Is
just
there
disconnect
any
from
need
here.
to reduce it?
No, we don't reduce it. We do not optimize. You can just pull it. That's the stylet coming out from the catheter. These catheters are styleted catheters. There's the stylet of the catheter that we just pulled out.
Yeah, that's what I was wondering, because what is conducting the current? The stylet is a metal stylet, correct?
Yes.
Okay.
So we're going to take the.
Is the stylet which conducts the current rather than the edges of the catheter?
Yes, it is both. It is both.
Both?
There is yes. There is on the tip of the. I'm going to tunnel it. So
What
we'll
is the
take.
material of the catheter?
I don't know
Is
what
it-
the material is.
How does it conduct the current?
Oh, because through the stylet, and then on the tip of the catheter is a bullet-tipped metal part that actually conducts the current at the
Dilated
tip.
catheter is from which company?
This is from Arrow. So I'm going to now tunnel the catheter. So I'm going to create a skin wheel on the lateral aspect, tiny pinch. I'm going to create a wheel, and we'll infiltrate the track that the Twin needle is going to take.
That is for fixation of the catheter.
Yeah, that is for the fixation. Then we bring the needle very close to the insertion.
Just a basic question.
And then I'm going to put the catheter from the sharp end of the needle, bring it out.
Just a basic question, what is the advantage of a stimulating catheter or an ordinary catheter?
Well, you have more, you are sure that the catheter tip is where you want it to be. Then we'll go ahead and on the catheter.
Once the position is established, there is no need of any stimulation later on.
No, no, and then we're going to basically clean this area and tape it. And we still haven't injected any local anesthetic because we inject it, you know, after everything is all set up. So we'll go ahead and tape it in place. So this is tincture benzoin. Yeah. We'll break the cap. We'll take it. That's fine. Go ahead and get some tincture on the skin. Oh, that one. First that. Actually, you know what? I'm going to first do that. So, for this is steri strips.
What is the typical indication for such type of procedures?
So we do it for total knee replacement,
For surgical anesthesia or post-op analgesia?
for post-op analgesia.
Yeah. And what technique of anesthesia is used for such cases for during anesthesia?
Either a light GA with an LMA. It will do. That's why I'm not going to finish the.
Any method to control the sciatic component?
In our hospital we do a selective tibial nerve block to control the posterior knee pain.
Have you compared with lumbar epidural analgesia for joint replacement, knee replacements? With
The
this femoral?
epidurals, they work just as good as femoral catheter in terms of the quality of pain control, but there are more side effects that are involved with the epidural. So you know they have increased, you know, hypertension, itching, urinary retention from the fentanyl that we put in the epidural infusion. They can get respiratory depression. So you get a lot of.
Okay, in your opinion, usually you prefer to have a post-operative analgesia for
we
TKR
don't
surgery
have to
with
give
this.
anything. You can give it just before you're ready to. So the surgeon still hasn't arrived, so we won't inject anything through the catheter. When the surgeon arrives, they can infiltrate. They can inject. Usually, we'll inject about 0.5%, 15 cc's of local. Oh, we had held the probe just like this, and the needle was sort of stabilized, you know, just like that.
What is the... Hello, Dr. Sinha, can you hear us?
Yes.
What is the drug plan now, though you are going to inject it later?
So we'll inject about 15 cc's of 0.5% Marcaine, if that is, or bupivacaine that is available, and that will be fine.
Otherwise, for the surgical analgesia, what exactly do you use? Light
I think they're going to do either a GA or I don't know what. They're going to do a light GA for this patient because he's having a complex cruciate ligament surgery, PCL repair. So either a spinal or a light GA, and this will provide the analgesia post-op. You can take that up.
Dr. Pandey, we are going ahead with the obturator block now in the same patient.
Yes, yes.
And we are ready with another patient where Dr. Amjad is going to show ultrasound guided popliteal block.
You have the ability to. There's nothing coming back. Operator nerve block.
On the same side.
Here's the femoral artery. Down below is the pectineus muscle. In the adductor longus and the brevis, that you have the anterior branch of the operator nerve, and down below is the posterior branch of the operator nerve. We'll try to elicit a motor response. If we can't, we really don't have to. You can just infiltrate in the interspace and you'll get a block. So again, local. So again, just some local.
Hello?
Yeah.
Can it be heard in the auditorium? Yeah, okay.
So just infiltrating some local. Again, it's a fairly deep block, so we infiltrate fairly generously. You can hook it up to stimulator.
Do you need to block both the branches separately?
Yes. And if you can hook this syringe to the thing and flush it. So one end is hooked up to the stimulator of the needle, and the other end, that's good. And we have flushed the needle. Just want to create a little better space. Okay, that's good, that's good. Okay, so there I think, that is where I think is the anterior branch. So I'm going to, sorry. Oops. I just want to move this. Move it back. So I'm going to get in a slightly better position.
Is it in plane, out of plane?
It is in plane.
In plane. And the entry point is from the medial aspect or lateral aspect?
Oh, sorry. Oh, okay.
Entry point is from lateral side.
Can we give him some sedation or no? So there's my needle, and
Yeah. What are the muscles you went through just now?
we went through the adductor longus muscle basically,
Okay.
and my needle is right there, and you can actually see the contraction of the adductor muscle group on the medial aspect of the thigh. I'm just going to leave it here so that you can actually see the adductor muscles contracting.
Okay. Now this plane, the point of the needle is in between two muscles, and which are these two muscles?
The adductor longus is superior, and below that is the adductor brevis.
Okay.
Okay. No, you don't have to. We leave the current at 1. We don't really try to optimize the current. What I'm more interested in is actually the spread of my local. So 1 cc injection, and as soon as we inject, the current is going to get abolished. Go ahead, 1 cc. And as soon as we injected a cc, the adductor muscle contractions were abolished. Another cc. And another one. Another one. And one more. And so we inject usually about 5 cc's or so for each branch. Now we'll go ahead and find the posterior branch, which is
In the same direction you'll go?
we'll go in the same. We'll just pull back a little bit. You can turn the stimulator. Just turn it down, the current down. No, don't turn it off. Just current down. We usually like to turn the current down as we go through the muscle layers, because you don't want the distraction of the muscles while they're contracting while you're going through these deep muscles. So we'll turn it down, and when we get to the right spot, it's only then that we turn on our stimulator. So I'm going deeper.
So longest by the side of brevis, you are going further down.
Right. And sorry. So because of the way that I'm sort of positioned, I can't.
What is the depth beyond the point of injection now which you are done?
Just 1 second. I'll tell you the depth in 1 second. I just
Okay.
want to bring my needle to the target nerve first.